Part of sabiston, voiding dysfunction, neurogenic bladder, incontinence, and BPH. Okay, so first is neurogenic bladder. Okay, so bladder storage is related to sympathetic. Okay, S for S. Okay, S for S. Okay, and that receptor is alpha adrenergic receptor. Okay, so most common adrenergic receptor in a bladder, prostate, and urethra is alpha adrenergic. Okay, okay, means lower urinary tract. Okay, the which type of alpha 1 and alpha 2. Overall alpha 1 is most common subtype of lower urinary symptom. Okay, okay, now come to the bladder emptying. So bladder emptying, that is pass for parasympathetic, P for P. Okay, so it is through cholinergic receptor, and that especially via the muscarinic. Okay, muscarinic receptor. Okay, so which type? M2 and M3. So remember 1, 2 and 3. So 1 is alpha, 2 and 3 is muscarinic. Okay, okay, so it is carried through myelinated and unmyelinated afferent nerve fiber. Okay, and through pudendal, pelvic, and pudendal nerve. Okay, so remember it's a P. Okay, pudendal, pelvic, parasympathetic. Okay, okay, that no, that is sensory information is carried from the pelvic and pudendal nerve. Okay, okay, not parasympathetic, sorry. Okay, okay, so interruption in sympathetic and parasympathetic nervous system leads to the neurogenic bladder dysfunction. Okay, okay, so voiding is initiated at the level of pontine micturition center. Okay, okay, and the pontine micturition center is inhibited by the periaqueductal gray matter located in a midbrain. Okay, so 4P, pons, pontine micturition center, related to voiding, that is pass. Okay, and inhibited by again P, periaqueductal gray matter, midbrain. Okay, midbrain is just above the pons, remember that. Now come to the spinal cord lesion. Okay, so two type of spinal cord lesion: suprasacral spinal cord and sacral or peripheral spinal cord lesion. So in suprasacral, it could be spinal cord injury or infarct. In sacral and peripheral spinal cord lesion, it could be pelvic plexus damage from surgery, diabetes, neuropathy. Okay, diabetic neuropathy. Okay, now suprasacral spinal cord tends to increase bladder muscle tension. Remember, like upper motor neuron lesion. Okay, and abnormal elasticity of the bladder. Okay, so which lead to poor bladder emptying. Okay, now is because of this incoordination of the bladder urinary sphincter. Okay, okay, and which finally lead to detrusor sphincter dyssynergia. Okay, patient with sacral and peripheral nerve lesion tend to have LUTS, lower urinary tract symptom. Okay, but not have changes in bladder elasticity. So bladder elasticity related to the sympathetic. Okay, not suprasacral. Okay, okay, then partially or completely non-functional and urinary sphincter remain the closed. Okay, if a detrusor muscle is often partially or completely non-functional, and which lead to urinary sphincter remain closed. Okay, that's why LUTS as a symptom. Okay, so in which surveillance cystoscopy is indicated, and the treatment of neurogenic bladder is this botulinum toxin. Okay, ona botulinum. Okay, this ona. This is complex regimen of anti-muscarinic agent. Okay, so ona botulinum is most patient treated with periodic cystoscopic injection and intermittent catheterization. Okay, okay. Now come to the overactive bladder. So it is most common storage related problem of the bladder. Okay, so most common overall most common storage related problem is OAB. Okay, okay. Now there are few terms like urinary urgency. So and how it is defined? OAB. So urinary urgency with or without urinary incontinence. Okay, so urinary urgency is main thing. Okay, so in absence of UTI or obvious disease. Okay, okay, so urgency, what is urgency? So sudden compelling desire to pass urine that difficult to defer and replaces the normal urge. Okay, all words are important: sudden compile, desire to pass urine, and difficult to defer and replace normal urge. Okay, so what is nocturia? So interruption of sleep, one or more. So at least one time, okay, because of need to urinate, okay. Finally, urge urinary incontinence. So incontinence means involuntary passage of urine. Urgency means with urgency, okay, very easy. Now come to the what are the factors which lead to OAAB. So caffeine intake, constipation, recurrent UTI, pelvic organ prolapse in female, and prostatic enlargement in male, and excessive fluid intake. Okay. Okay. So the first line treatment for OAB is behavior therapy. Okay. So lifestyle modification or specific physical therapy in which we advise to take how much fluid to take and at what time. Okay. So modification of fluid intake. Okay. Particularly the timing and amount. Okay. Then bladder training is non-invasive method of physical therapy. Bladder training is a non-invasive method. Okay. So patient postpone voiding to lengthen the time of intervesical between the void. Okay. So you should maintain the voiding diaries. Okay. So pharmacological management continue the mainstay of treatment. Okay. So what is the mainstay of treatment? Pharmacological. And the initial management is behavioral therapy. The first line and initial whatever. So it is behavioral therapy. Mainstay is pharmacological therapy. Okay. So classic pharmacological therapy is anti-muscarine therapy. So directed against the M2 and M3. Okay. Okay. A newer pharmacological agent, beta agonist 3 target also used. Okay. So specialized third line treatment include neuromodulation. Okay. So initial mainstay and the third line is neuromodulation. Okay. And botulinum toxin, chronic indwelling catheter, and augmentation cystoplasty. Okay. So last is urinary incontinence. So incontinence means involuntary loss of urine. Okay. So it could be stress urinary incontinence, urge urinary incontinence, and mixed. Okay. So overflow incontinence is another form of incontinence. Okay. So which often considered the separate entity. Okay. So females mostly age of over 20, and men over the age of 50 affected with this. Okay. So stress urinary incontinence defined as involuntary loss of urine with Valsalva maneuver, because stress word is there, so you have to give Valsalva. Okay. So urge urinary incontinence, so involuntary loss of urine associated with strong urge to void. Okay. Urge. Okay. And there is a mixed. Okay. So mixed. Okay. So dietary modification is important for management of urinary incontinence. Okay. So limit fluid intake up to 2 liters per day, limit caffeine intake, alcohol, carbohydrate, and spicy foods, and citrus juice and fruit should be avoided. Okay. Okay. Weight loss to a normal body mass index. Okay. So weight loss is also okay. Okay. Poor pelvic anatomic support in female, and in sphincteric in typically poor pelvic anatomic support in female and in sphincter in men. In female, you can give the injection of urethral bulking agent, urethral bulking agent, the simplest treatment. Okay. And through the cystoscopy. Okay. The mid urethral sling to support the central hammock. Okay. So next step. Okay. Next option. Okay. Then highest success rate is given through the mid urethral sling. Okay. Okay. So male urethral sling is also there, and artificial urinary sphincter is also there. Okay. Okay. Now come to the most important topic is BPH. Okay. So what is BPH? Enlargement of stromal and epithelial component. Okay. So 70% of men develop BPH at age of 60 to 70, around 60 to 70, 69 years. So at 70 years, 70% male. Simple. Okay. So degree of bladder outflow obstruction does not necessarily correlate with severity of LUTS. Okay. So not necessarily. Okay. So PSA testing appropriate patient with life expectancy is more than 10 years. This is also important. Okay. Okay. So mainstay treatment for LUTs in BPH is alpha 1 adrenergic receptor blocker. So one is one. Okay, so first is alpha 1 blocker. So alpha 1 is most common subtype. Action of alpha 1 blocker is to relax the smooth muscle in the bladder, neck and prostate. Okay. So most common side effect of this drug is dizziness, orthostatic and because dizziness because of orthostasis, retrograde ejaculation and rhinitis. Okay, so next is 5 alpha reductase inhibitor. So target the glandular component of the prostate and block the conversion of testosterone to dihydrotestosterone. Okay, and reduce the prostate volume. Okay, so it alters the PSA level, so reduce it by 50%. So it is, remember, when you are going to examine PSA, okay, during screening. Okay, so surgical indication we should do when patient is acute urinary retention, bladder calculi, azotemia, recurrent UTI or recurrent hematuria. Okay, so standard approach for surgical treatment for BPH is TURP, transurethral resection of the prostate. Okay, so adenomatous growth is particularly large. If suppose there is prostate adenoma, so you should do open simple prostatectomy. Okay, to perform enucleate the adenoma surgically. Okay, okay, and this is the picture of BPH. Okay, asked many times. Okay, so sometimes they ask what are the recommended tests in LUTs in men. So you do urine analysis, serum PSA and frequency volume chart. Okay, okay. So other one is what is polyuria and nocturnal polyuria. So polyuria is over 24 hours more than 3 liter of urine. Okay, nocturnal polyuria is more than 33% of urine output at night. Okay, so complication of TURP procedure. So what are the complication of TRP? This is old age famous question. So persistent bleeding, dilutional hyponatremia because of using fluid glycine, okay, and UTI, urinary incontinence and urethral stricture. So to avoid this hyponatremia, we use bipolar or laser or normal saline to irrigation. Okay, okay, okay. So this much you should know about this. Okay, thank you.